Hello everyone, my name is Dr. Dima El-Sharkawi and I'm a haematology consultant at the Royal Marsden Hospital. I treat patients who have lymphoma and CLL, and I'm also clinical lead for our diagnostics unit, and that's where we diagnose different blood cancers including lymphoma and CLL. So in this short video, I'm going to talk to you a bit about low-grade non-Hodgkin's lymphoma and what it means. So lymphoma is a cancer of your lymphocytes, and your lymphocytes are one of your white blood cells, and their normal function is to fight infection. You have B lymphocytes and T lymphocytes, and either one of these can become cancerous. And low-grade non-Hodgkin's lymphoma is a form of B-cell lymphoma. So it's lymphoma affecting the B lymphocytes. Now, there's many different types of B-cell lymphoma. We have a subtype called Hodgkin lymphoma, and anything that's not in that diagnosis comes under this umbrella term of non-Hodgkin's lymphoma. Non-Hodgkin's lymphoma is a constellation of different lymphomas. So there's lots of different subtypes of B non-Hodgkin's lymphoma. But broadly speaking, they can be split into low-grade or high-grade B non-Hodgkin's lymphoma. And that really reflects how quickly the cells are dividing. So as you might imagine, those patients with low-grade B non-Hodgkin's lymphoma have slower growing lymphomas. We sometimes label them as indolent lymphomas, that they're very slow to divide. And so because of that, patients can often present fairly well. So often patients can present happening to notice a lump either in their neck, under their arms, or in their groin area, but otherwise no other symptoms. Sometimes we pick up these lumps if patients have had a scan for another reason. Then we can see on the scan that they have enlarged lymph nodes. This can raise the suspicion for lymphoma, but the only way to diagnose any cancer, and lymphoma included, is by biopsy. So we need to take a sample from the abnormal lymph node to look at it down the microscope, to do further tests, to diagnose not only the lymphoma, but the subtype of lymphoma. Once we've made the diagnosis, the next step is to perform a staging scan. So that's to say, we know the disease is where we took the biopsy from. Where else in your body is it? Now, tests don't always happen in this order. So some people have had the scan before they've had the biopsy if there's been a high index of suspicion. But the scan helps us to stage the disease. So staging for lymphoma is slightly different to with other cancers in that the majority of patients who are diagnosed with lymphoma, the disease will be in more than one place. Remember, this is a cancer of one of your blood cells, and as blood travels around your body, either in the bloodstream or in the lymphatic system, so it's quite common for us to see the lymphoma in several different places. And this gives us a baseline to help us see and know exactly where the disease is before we start treatment. And it can sometimes affect what treatment we give or how much treatment we want to give, depending on the stage. But it doesn't have quite the same connotation for us as it does with other cancers, where we know it makes a big difference in other non-blood cancers and non-lymphoma cancers, where it makes a big difference if the disease is in one place versus several places and it's spread. For us, most of the time, it's in several places. So once we've made the diagnosis of the low-grade B non-Hodgkin's lymphoma, we've performed our staging, which usually is a scan, could also be some blood tests, and sometimes we do consider a bone marrow test as well, although these are less frequently done. But sometimes if patients have low blood counts or another concern, we may want to perform a bone marrow to see if there's disease there as well. So once we have the staging, then the first thing we think about is, does this patient need treatment? Now, this may seem a bit odd to you all that you've just been told that you've got a cancer, a form of lymphoma, but that we're not going to necessarily treat it straight away. And the reason why we do this is that we know we've got treatments that are very good and very effective, but they don't get rid of low-grade lymphoma completely. So they will shrink it down and potentially shrink it to such a small volume that we can't detect it anymore with our usual tests. But we know that this is not curative treatment. And so because of that, there have been lots of trials in the past to see whether there is any advantage in treating patients straight away as soon as they're diagnosed versus waiting until patients have symptoms or there is a concern that they need treatment because they may develop symptoms. And there's no difference in how long someone lives for. And so if patients are diagnosed when they're relatively well and the disease is relatively low volume, so there's not much in the body, then we may just observe the patient and monitor the patient in clinic. You may hear healthcare professionals refer to this either as active surveillance, which is often our preferred term now because we are closely monitoring patients during this period. But sometimes we still refer to it as watch and wait. As I said, this can be quite a hard concept to understand because it does go against everything all of us know about cancers, about early diagnosis and early treatment leads to better outcomes. But with low-grade lymphomas, that's not necessarily the case. So when we're monitoring patients in clinic, the key thing is, do we think the disease is progressing such that patients are going to develop problems and run into problems, whether that be symptoms or it starts to affect their organ function? Or do patients have symptoms currently that mean that they need treatment for their lymphoma? And at that point, when we think one or more of those things are happening, then we talk about treatment. Standard treatment is what we would refer to as systemic therapy. So that's therapy that treats the whole body. So by and large, for the first lot of treatment for low-grade lymphomas, that involves chemotherapy because chemotherapy treats the whole body. The chemotherapy is given in conjunction with antibody therapy, and the antibody therapy is a more targeted way of treating B-cell lymphomas, as the antibodies target a protein that's on the surface of all the B lymphocytes, so your normal ones, but also the bad lymphoma B lymphocytes as well. And so most low-grade lymphomas are standard. First treatment is a combination of antibody therapy plus chemotherapy. We sometimes consider radiotherapy as well for some lymphomas, particularly if it's just in one or two places, or there's an area that is particularly causing problems or very bulky, then we may consider radiotherapy. And there are newer therapies and coming all the time. And there are now some therapies that we use that are more targeted therapies that target enzymes that we know are overactive in lymphoma cells. But these tend to be used as subsequent treatment. So not as the first treatment for the low-grade lymphoma, but perhaps when patients need treatment again. Because as I said, we know the treatment isn't curative. So what we aim for is to try and induce a remission, that the disease, when we start treatment, the disease goes down significantly. And then what I tell my patients is that it's almost back to square one once we've completed the therapy, that we monitor them in clinic again, exactly as we did before they needed therapy. So we monitor them for periods of time, and that may be potentially years. We have one or two patients that have been in our clinic and not needed treatment for over 10 or even 20 years after their first treatment. But when the disease comes back again, then we treat again. And that's the usual pattern with low-grade lymphomas. We monitor until patients need treatment, give the treatment, the disease goes down, we monitor again, until it needs treatment again, give more treatment, etc., etc. Overall, the outlook for low-grade lymphomas is very good, although the disease is not curative, which can be quite a shock when you first hear that. we've got very effective treatments that can keep the disease at bay for long periods of time for the majority of patients. And as I've already said, treatments are changing all the time, and our treatments are becoming more sophisticated now. In fact, at some point when you need treatment, if there is a clinical trial available, it may be discussed with you, and you may be offered that opportunity to go on a clinical trial to investigate some of these treatments or to look at a better way of giving some of our existing treatments. Overall, as I've said, given that it's not curative, once you've met your hematologist, you will get to know them very well, because in some ways this is more of a chronic condition, because even when your disease is in remission, we won't necessarily discharge you from the clinic because we will be keeping an eye until the disease comes back. And so any issues that you have, it's always worth talking to your doctors and your specialist nurses in the clinic. Thank you very much for listening.